Is it visible now?
Yes, doctor. Please put it in slideshow mode.
Yeah. Okay. So as pediatricians, we are very used to the concept of dehydration, of vomiting, of replacing fluid losses. So sepsis is a little different because a child with pneumonia, yes, maybe vomiting a bit, maybe not taking as much fluids as usual, but it's not that they need even more fluids than the severest diarrhea patient needs. So in the most severe diarrhea, we give about 15 to 20%. We're saying 20 and 20 and 20. So why is it a child with pneumonia or maybe abdominal sepsis or a cellulitis? Why should they need so much fluid? So there's a lot of data in adults, and they are moving away from large volume fluids. In pediatrics, we have been a little slower to move that way. And basically, the slide says the same thing, that hypovolemia may occur to some degree, but the pathophysiology is far more complex compared to a pure fluid losing state. So what confuses us is that a dehydrated child with diarrhea or a dehydrated child, a child with septic shock, both of them may have tachycardia, cold extremities, decreased urine output, and acidosis. So the presentation is similar, but it's rather simplistic to assume that the response to fluid in sepsis and fluid losing states are similar. So you have some hypovolemia. There's also change in the vascular tone, and there's some cardiac dysfunction, which occurs in a kind of mix and match kind of proportion. So it's kind of hard to know what is happening when you first approach a child. And I feel it's totally wrong to assume that just because for meningitis we give 100 milligram per kg of ceftriaxone, for septic shock we have to give 60 per kg of fluid. It's a different concept. Antibiotics is a fixed dose, but sepsis you need to find out that the dose that the child actually needs. So what we know in the past few years is that in about 1/3, fluid boluses can actually improve the cardiac output. So that's what we want. Improved cardiac output means a cold extremity becomes warm, a decreased urine output improves, the child is more alert. So that's what we want. But this effect may be sustained only in a few, and I'll demonstrate that in the next slide. Moreover, fluids do a strange thing in septic shock. They actually vasodilate and decrease the BP. So in some children, it can vasodilate, in some it can increase the BP, and some it can lower the BP. And it's a little hard to predict what is going to happen in the given child in front of you. In some children, it can actually decrease the cardiac function, both systolic and diastolic, and fluids can increase capillary leak. So we know in dengue that if we push fluids too rapidly, immediately there's more leak. Likewise, we are just finding out that septic shock behaves in a similar degree. But if you give fluids fast, the capillary leak is more. If you kind of slowly fill them up, it may be a better strategy. So this was a very interesting study done in the emergency room in Royal Children's Hospital in Melbourne. So they demonstrated that if fluid boluses are given to a child with shock, in the first 5 minutes, you can see here the cardiac index. So this is 0 and this is 5 minutes. The cardiac index actually improved, but unfortunately, the improvement was not sustained. So you can see at 60 minutes. So to a clinician who's the bedside, poor volume pulse, give fluid, it improves. But a clinician is rarely going to stand there without moving for 60 minutes. And at the end of 60 minutes, whatever was there, the fluid is actually cheating you. It's improved and then gone back to the same low cardiac output state. So this is to do with capillary leak. So wouldn't it be better if we have other ways of circulatory support that is more sustained? We need to explore such strategies. So basically, if a lot of fluids are given to a patient, you can keep the ICU personnel really busy. Okay, so if you think your poor ICU fellows and consultants are not having much work, simply give them a lot of fluid, 20, 20, 20. There's more need for rescue ventilation, more need for the hearts are swollen, it won't function well, so they need inotrope. Then they're fluid overloaded, you call the nephrologist and do dialysis. So there's longer stays, more expensive stays, and not necessarily better outcomes. In fact, it may be even worse outcomes. So is this a very good thing for us to be doing here in India and Chennai, just load them with fluid? Maybe not, but we need, in order for guidelines to change, we need some evidence. And that is what we tried to do during the pandemic. We had 2 international publications on fluid bolus study in 99 children with shock, 2 very different populations. So we have a busy cardiac program. So we simply gave fluid to children after cardiac surgery, and because some of them were in low cardiac output, and then looked at the response. The second half was in septic shock. So I'll describe our findings in septic shock because that is what is important for us. But strangely, if I ask you which population did worse, most people would say the cardiac population did worse with fluids, right? You would think children with bad hearts did worse. But strangely, the septic shock patients actually did worse with fluid boluses. There was an improvement in MAP. So it's overall pretty similar, but improvement in the blood pressure and cardiac output in only a fourth to a third of patients. And we couldn't really, there was no link. So we couldn't say the BP has improved, the cardiac output has improved. No, there was no correlation between the MAP and the cardiac output. And in fact, almost 50%, the blood pressure came down and we needed to dial up their pressure requirements and even start some pressors in patients who are not already receiving it. So you can see here, we included patients who came pulseless and who needed intraosseous access. This was in the emergency room. So we included patients soon after they came in, anyone who in shock who required fluids. And we looked at the cardiac index and MAP and their relation to each other. So this was a study in both populations. So basically, children with shock got 10 ml per kg over 30 minutes. And after 10 minutes after the completion of bolus, we looked at all the same parameters. So we classified them as fluid responsive if their cardiac index improved. So that means the pulses are better, the acidosis is better. And we classified them as MAP responders. So there are 2 things we looked at here, their blood pressure and their cardiac output. So we looked at both. And we also looked at something called perfusion pressure, which I'm not going to go into because it's a hardcore ICU area, right? So we got a lot of lot of our fellows who are very keen to do a lot of, our previous speakers talked all about technology, and our fellows are very, very happy to do repeated monitoring and note those values. You can see here, we got the, so in the ICU or emergency room, we looked before and after the fluid. We did the echo and lung ultrasound and also something called electrical cardiometry, which non-invasively gave us cardiac outputs and systemic vascular resistance readings. So among the 42 patients in the pediatric ICU and ER with septic shock, we classified them as cardiac outputs and a responder or non-responders and the MAP responders. So you can see here, they were a reasonably sick population, but what was striking was if the MAP didn't respond, it kind of red flagged the fact that this was a sicker patient and they had a more complex cause. The MAP just didn't respond. And so the non-MAP responders, rather than the non-cardiac output responders, were the ones who were at higher risk of death. So what was happening is that we know when a child is dehydrated, their systemic vascular resistance goes up in a compensatory effort to maintain blood pressure. But in sepsis, that whole compensation has gotten, exaggerated. Even when the SVRI was already low, the fluids made it even lower. So this was causing a lower MAP. So it's not just the fact that the MAP is fallen. The MAP actually determines organ perfusion pressure. That means how well the brain is getting perfused, the heart itself, the heart, the lungs, the kidney, the liver. So the MAP is the upstream pressure that determines organ perfusion pressure. And the fluid is actually decreasing perfusion pressure to various organs, sometimes even in patients whose cardiac output is improving. So as I said earlier, there was no connection between the MAP and the cardiac output. So how can we decode the pathophysiology of pediatric septic shock? Just remember that every child is telling you a story, and you have to be very alert to listen to the clues from the response. So give a fluid response, give a fluid bolus by all means, but listen to the entire story. So what are the steps of the story? Has the cardiac output or clinical markers improved? Has the MAP increased or decreased? And if there are any features of fluid intolerance. Shamla, how much time do I have left?
I have 2 minutes left.
2 minutes? You were supposed to tell me. Okay, if the MAP falls or fluid intolerance occurs, you need to consider earlier vasoactive. So the fluids were the main part of my talk, and I'll quickly go through my remaining slides, which is also a part of our research, to say that if a child is in vasodilatory shock, they are not really they have something called a relative hypovolemia, because these are all dilated vasculature and the blood is just sitting there. Rather than coming back to the heart, it's just sitting there because the vascular capacitance has increased. So there's a great move to low dose early norepinephrine or even dopamine, which will gently squeeze that expanded vascular compartment and coax it back to the heart. You can actually improve the venous return even without giving fluid. So after that initial small bolus of fluid, you start NORAD. And this was another research that we did about 3 or 4 years ago. And we showed that although the mortality wasn't different, whether we use a lot of fluid or early norepinephrine, the fluid used was much less. And this translated to lesser days on invasive ventilation and a less time in the ICU. So certainly a lot of cost savings when we did a more individualized approach rather than extra fluid. So basically, fluid boluses are important and essential in fluid losing states. There's absolute hypovolemia, but in sepsis, there may be only small deficits. And remember that fluid improves cardiac output and BP in only a third or so, and these improvements are not sustained. And the others of fluid can actually worsen lung organ perfusion and vasodilate and increase the need for ICU support. So earlier low-dose vasoactives, especially in our setting, so we don't have the luxury of free treatment for all and lovely, all the high technology all coming free. There's very good evidence that early low-dose vasoactives is better than large volume fluid, both in adults and in children. And I'll conclude by saying that cardiovascular management in septic shock really depends on the physiology, and we should treat each patient individually and not give automatic, protocolized treatment in all. Individualized is the way to go. Thank you very much for the opportunity.
Thank you, Dr. Suchitra, for finishing on time. So we'll now move on to the
I think you have muted yourself.
Question for Dr. Bakul. What are the medico-legal implications of digitalization?
Basically, medico-legally at present, during COVID time, government has allowed us to do teleconsultations, but definitely you are supposed to keep your records. And if you give the treatment as per the protocols which what we follow during our physical consultation, if you follow the same, and if you can say that best possible treatment was as per the situation was the one which you are given, then you are protected. You are not supposed to take physical consent, but definitely when a person contacts you for teleconsultation, it is taken as a consent. But if you contact patient directly, then of course you will have to take a consent from them or her, he or her, based on your WhatsApp or whatever media you are using, and they should write it on that I am agreeing to what you are advising. If you follow these few principles, I'm sure, and in the best interest of the patient, whatever you have done, if that can be proven, then you are not going to be affected by medical legal aspect.
And another question for you, Dr. Bakul. What about acceptability of digitalization by senior pediatricians?
Very difficult question, because at present the senior pediatricians are not yet exposed to what we are supposed to do digitally, except for the teleconsultation. Many of the senior pediatricians and consultants are using teleconsultations there in present COVID situation, but otherwise they are still following the same old methods of examining the patient and advising them, which otherwise many of the youngsters are following many digital techniques, EMR, writing the prescriptions on your electronic media, and all those things are being followed by youngsters, but seniors are still averse to that.
Thank you, Dr. Parikh. Question for Dr. Suchitra. Very lucid talk and so clinical and inspiring. Now, question from Dr. Tangavelu. How much is clinical assessment for shock and fluid responsiveness useful?
Yeah, I know I'm talking to a great, I'm answering the question from a great clinician, and I very much was keen to continue the fluid clinical assessment to guide shock management. But after many children have kind of not followed the rules, unfortunately, they should read our research and then come to the hospital, but they're not. They refuse to do so. They follow their own script. So clinical examination is good to detect shock, is good to tell you whether your treatment is working or not working, but it's not so good to guide treatment. So what I mean is, you're given one bolus, the child is still tachycardic. That tachycardia and decreased urine output will not guide you whether the child needs more fluid, needs an inotrope, or needs a pressor, or even if he needs fluid removal. So the field is wide open. So it's not that great, and that's the reason we started doing echo straight after the first bolus. I do understand that it's not practical and relevant or even logistically a good idea for me to say this, but I'm just saying what we do in our hospital.
Okay. What is your comment on administration of noradrenaline in septic shock? When would you give it?
So we kind of, I think the first thing that happened was for us to acknowledge that pediatric septic shock is similar to adults. And then it's easy to follow the same treatment pathway. So they give some fluids and start NORAD, but very quickly you need to kind of see if the NORAD is helping or not. So even if you don't have an echo, that, as I said, clinical examination is very good to tell you if it's not working. So the tachycardia goes up, the heartbeat is increasing by more than 20 points. The pulses which had come back have disappeared. So the BP is in fact falling even with NORAD. So you know that something's going on. So you might need to change your strategy. So early NORAD worked for the majority. In about 1/3, it may not work. Clinical examination can tell you it's not working. If you have an echo, you can find out and fine-tune your next step.
Another question. Non-invasive cardiac output measurement may not be available in all centers. What is your advice?
Yeah, this is purely for the research, as a research article. So we have to show numbers. But as I said, your clinical examination is good to detect shock. to tell you that if your treatment is working or not. You don't need a number. You don't need to know if the cardiac output is 3.3 or 5.5 or 10. It doesn't really matter. You don't really need it.
Okay. I think that's all for the questions we have. I again thank all the speakers for a wonderful presentation and lucid discussion. You've really set the pace for the rest of this. We move on to the next session. I'll call Dr. Sridevi to moderate the next session. Dr. Shankar will be our, yeah, thank you so much. It was a really wonderful listening to you all. Thank you, Dr. Parekh. Thank you, Dr. Piyush.
Thank you.
Thanks. Bye-bye, Doctor.